Hello, my name is Maximilian Frank. I'm part of the Medical Product Competence and Research team here at Custo Med. In this video, we'll take a closer look at what hemodynamic phenotypes are and how we can derive them from 24-hour ambulatory blood pressure monitoring. The 24-hour ambulatory blood pressure monitoring, or ABPM for short, provides us not only with systolic and diastolic blood pressure, but also with the pulse pressure. And pulse pressure is very simple. It's just the difference between systolic and diastolic blood pressure. When we evaluate a full 24-hour profile, we can identify whether a person has systolic hypertension, diastolic hypertension, or a combination of both. We also see whether the pulse pressure is normal or elevated. This is important because pulse pressure gives us insight into the function of the large arteries. From this combination, 4 hypertension subtypes emerge. First, isolated diastolic hypertension. Second, isolated systolic hypertension. Third, combined systolic diastolic hypertension with normal pulse pressure. And fourth, combined systolic diastolic hypertension with high pulse pressure. Each blood pressure pattern has its own causes and influencing factors, and dividing these patterns into subtypes is a meaningful first step toward understanding them better. Let's briefly look at the basics. Blood pressure is the force with which blood is pumped through our vessels. It depends on the one hand on the heart, how strongly and regularly it pumps, and on the other hand, on the properties of the arterial walls, such as their elasticity. To simplify it, pressure equals flow times resistance. Blood pressure consists of 2 values, systolic and diastolic pressure, the 2 extremes within the vascular system. From these values, we can also calculate the mean arterial pressure, or MAP. It equals the cardiac output, the amount of blood pumped per minute, multiplied by the systemic vascular resistance. There is also the pulsatile component, pulse pressure, and this mainly depends on stroke volume and the elasticity of the large arteries. If we want to understand why blood pressure increases in some people, we need to look at the key contributing factors: stroke volume, cardiac output, large artery function, and vascular resistance. By the way, the resistance the heart has to pump against is also known as afterload, and not all vessel sections contribute equally to total resistance. A large part is due to the small arteries and arterioles. Other sections, such as capillaries, venules, and veins, also contribute, but to a lesser degree. Arterial hypertension occurs when one or more of these determinants are altered. One especially important factor is age, as it influences these mechanisms and therefore the type of hypertension that develops. In younger patients, we often see an increased stroke volume, while vascular resistance remains relatively normal. This often leads to isolated systolic hypertension and an increased pulse pressure. In people between roughly 30 and 50 years of age, the main change is often a clearly elevated vascular resistance. This typically results in isolated diastolic or combined systolic-diastolic hypertension. And in older adults, often aged 65 and up, we frequently see isolated systolic hypertension, mainly due to stiffening of the large arteries, which also leads to an increased pulse pressure. This age-related understanding is crucial for adapting the diagnosis and treatment of hypertension to each patient individually. Let's now get to the central question. How do we classify these hemodynamic phenotypes using 24-hour blood pressure monitoring? Based on ABPM data, we can distinguish various phenotypes that differ in their blood pressure regulation and underlying mechanisms. Let me introduce the most relevant phenotypes. First, the cardiogenic phenotype. Here, the heart is the main driver. It is characterized by a high stroke volume and high cardiac index. Heart rate is often elevated, while vascular resistance tends to be normal. Second, the neurogenic phenotype. This one involves the autonomic nervous system. Typical here is increased sympathetic activity. In other words, a nervous system that pushes blood pressure up. Pulse pressure and pulse wave velocity are usually unremarkable. Third, the volumetric phenotype. Here, the kidneys and blood volume play the central role. It's marked by a significantly increased stroke volume and elevated pulse pressure, often along with increased vascular resistance. Fourth, the vasoconstrictive phenotype. In this case, the small arteries and arterioles are the main problem. Systemic vascular resistance is high, while stroke volume and cardiac index are usually normal. Fifth, the stiffness phenotype. Here, the focus is on the large arteries, especially the aorta. Typical features are a high pulse wave velocity and elevated pulse pressure, clear signs of arterial stiffness. If we can identify and classify these phenotypes, we gain valuable insight into the underlying mechanisms. And that insight helps us tailor diagnostics and treatment for patients with hypertension more precisely and improve outcomes in the long term.